So now let us move to the discussion of iron deficiency, specifically iron deficiency anemia. Now, when you have deficiency of iron, one of the main consequences, of course, is going to be anemia, as we discussed. But in addition, because iron is involved in the function of other molecules in the body, enzymes, and so on, you also get abnormalities in catecholamine metabolism, resulting in vasomotor disturbances. You get numbness and tingling sensations and neuralgic pain in the extremities. In addition, a lot of epithelial abnormalities are observed involving the skin, the nails, even the tongue is affected with a sort of inflammation causing glossitis. And you'll see examples of these later or pictures of them. In addition, children who suffer from anemia chronically may have behavioral and learning problems. And there is in general a decrease in the heat production. So as you can see, the symptoms that result from iron deficiency are partly going to be due to anemia itself, and some of them are going to be unrelated to the anemia, but related to the iron deficiency itself. So when iron deficiency happens, and it can happen as a result of three general categories of causes. You either have a decreased intake, as you would get in situations of malnutrition or malabsorption, or you have an increased requirement, as we mentioned earlier, in infancy, pregnancy, and in menstruating women, or pathologically if you have an increased loss of iron from the body, and that usually indicates that there is a bleeding somewhere in the body, usually from the GI tract. So the iron deficiency therefore causes the anemia, which is a typical microcytic and hypochromic anemia, as we discussed when we talked about hemoglobin and loss and deficiency of hemoglobin. And then there are the non-RBC related effects. They have to do with myoglobin, with other heme-containing enzymes like the cytochromes, xanthine oxidases, mitochondrial enzymes, as we said, behavioral problems, catecholamine problems, and heat production. And as we said, the causes of iron deficiency: increased demand, such as in rapid growth, in pregnancy, or if you are treating a patient with erythropoietin being given to counter an anemia, to correct an anemia. If there is not enough iron, then this can cause iron deficiency in its own right. So you have to make sure that there is enough iron being provided when the patient is receiving erythropoietin, so that there will be effective erythropoiesis. Increased iron losses, that is, as I said earlier, and I said I would repeat this, if you detect iron deficiency anemia in a man or a postmenopausal woman, look for a cause, a pathological cause. Physiologically, menses can cause it, but pathologically, there could be chronic or acute blood loss that can cause it. And finally, as we said, inadequate diet or malabsorption, diseases causing malabsorption, which you will study later in the GI course. And this slide presents to you the progression of iron deficiency from a normal state to the full expression of iron deficiency anemia. And you can see that going from normal to iron depletion, what is happening is a gradual depletion of the iron stores. That top rectangle in that figure is the iron stores, and the lower one is the erythroid iron, that the iron found in the RBCs. So, in other words, you can maintain the production of RBCs and everything would look normal. You wouldn't get an anemia, but you are gradually depleting the iron from the stores. And the earliest and the most sensitive indice that this is happening is actually plasma ferritin, the third item on the table. You notice that it decreases from 100 to around 20. So that is an indicator that iron depletion is taking place. It has not reached a level where to cause iron deficiency anemia, but it's on the way there. And if you look at the bone marrow iron stores through a stain, a biopsy and a stain, you find that they are decreased from 2 to 3 plus to 0 to 1 plus. Transferrin levels start to increase. And of course, iron absorption, as we discussed earlier, in the regulation of iron absorption, when you have indications of iron deficiency, iron absorption is stimulated. And then to the next phase, when you have iron deficient erythropoiesis, now you start getting some decrease in the iron peripherally, but you still are able to maintain enough erythrocytes in the system to avert anemia. It is only when you get to the last stage, where you have depleted the stores completely and significantly depleted the iron in the peripheral circulation, that you get to microcytic and hypochromic anemia. And here all the indices show the abnormalities expected of them. And this is a summary in much briefer summary, that you can have normal iron stores or you can have latent iron deficiency. In both situations, you don't see an anemia, but you would differentiate between them by going to examine the iron stores either through ferritin or through biopsies and staining. When you get to iron deficiency anemia, that's where the hypochromic microcytic anemia appears. And the symptoms, as we said earlier, could be hematological, that are related directly to the reduction in RBC mass, which basically influences the delivery of oxygen to the tissues, or the non-hematological, which are related to iron deficiency, specific to iron deficiency other than the anemia. And the hematological symptoms, as we said, are related to the decreased oxygen supply. So the first thing you observe is fatigue because of a decreased oxygen supply to the tissues. And as a result, the body is going to try to compensate for this by trying to increase the delivery of blood to the tissues. So in stimulation of the circulation, increased cardiac output, increased heart rate, and people might get palpitations. And the other compensation is to try to get more oxygen into the system. And this eventually leads to dyspnea, increased breathing, work of breathing, leading initially to dyspnea on exertion, but then even dyspnea at rest. Finally, the people become lethargic. If there is marked depletion of oxygen, particularly in patients with atherosclerosis or cardiac disease, you may get myocardial infarctions even, and heart failure, as the heart is being overworked in these situations. Now, of course, these are the symptoms of chronic anemia, gradual development of loss of RBC mass. And one of the causes, of course, is bleeding, and this can be chronic bleeding, but you shouldn't confuse this with acute bleeding. In acute bleeding, you don't really get a decrease in hematocrit immediately because you're losing whole blood. The hematocrit decrease in hematocrit appears a few days later, or at least 24 hours later, when you have lost blood, but then you have reabsorbed fluid to compensate for it, and that's where the dilution of the RBCs becomes apparent, and you get a reduction in hematocrit and hemoglobin concentrations. And the symptoms of loss of blood, which is basically the symptoms of loss of volume, of intravascular volume and extracellular fluid volume, are thirst, fatigue for the same reason. Postural hypotension now here becomes important because you have loss of volume, syncope as a result of that, shock, and death. The non-hematological symptoms of iron deficiency are many, and Dr. Tfaili has already glossed over them. You have problems with tongue inflammation, which is painless, however, glossitis, fissures at the corners of the mouth called chylosis, changes in the nails to become brittle and concave, problem with swallowing if you get esophageal webs, craving for earth, for sand, for concrete, called pica or geophagia. Learning and behavioral problems, as we said, numbness, the tingling sensations, the extremities, and decreased heat production. And these are some of the, of course, pallor is a um, cardinal symptom of anemia. Pallor because you have decreased concentrations of heme in the blood perfusing the skin. Of course, you get this with anemia as expected, and you might get it in situations where you have severe vasoconstriction of the skin vessels. You don't have anemia there, but nevertheless, the result is the same, a decreased concentration of heme in the blood that is circulating to the skin due to the decreased perfusion of the skin. As you'd get, for example, when you have severe hypotension or an autonomic activation of the sympathetics to the skin, etc. When you have fear, when you're afraid, etc. This is the chylosis, which is here shown at the edge of the mouth, fissuring and ulceration. This is the smooth glossitis, red, smooth tongue. These are the changes in the nails, as you can see, the concave nails, ridged and brittle nails. And on laboratory examination, what would you expect to see? Let's try to explain all of these. Obviously, the hemoglobin concentration, hematocrit is low. The mean corpuscular volume, we said there is microcytosis, is reduced. The mean corpuscular hemoglobin in the red blood cell is reduced. The blood film shows the typical microcytic and hypochromic RBCs. The bone marrow, obviously iron is depleted. If you stain the bone marrow, you find depletion of iron stain. You don't see a stain. The serum iron is low concentration, but the total iron binding capacity, which is transfer in concentration, is increased. Protoporphyrin levels in the RBC are increased, and serum ferritin essentially is low. Whenever you want to diagnose iron deficiency anemia, the two things you can measure, give you an indication, is serum iron and serum ferritin. Iron deficiency anemia, this is the typical blood smear on the left, shows you the hypochromia in all of these cells, very little hemoglobin, and the microcytosis. And as you start treatment on the right, you see that some of the cells have become normal, like this one here, here. But there are cells transitioning. There is less hypochromia and bigger cells, and some of them have different shapes. So you get poikilocytosis, different sizes and shapes of RBCs. And this is the typical bone marrow of a normal person with a stain especially for iron, which is seen as blue here. And in iron deficiency, if you stain it, you don't see any blue. This tells you that there is iron deficiency anemia. So not every microcytic anemia, however, is necessarily iron deficiency. We discussed, again, we discussed this when we talked about hemoglobin, and we said at the time that anything that interferes with the synthesis of hemoglobin eventually can cause microcytic anemia. So reduced iron availability, obviously. This is maybe due to iron deficiency, or it could be anemia of chronic disease. And remember what we said about anemia of chronic disease, situation that is associated with decreased activity of the ferroportin protein that transports iron from the cells into the circulation and makes it available for the bone marrow. In these situations, you have a deficiency, a relative deficiency of iron delivery to the bone marrow. Many times this can be microcytic, sometimes it can be normocytic anemia. But then anything that reduces heme synthesis, whether it's one of the sideroblastic anemias that is involved a decrease in heme synthesis, or exogenous sources like lead poisoning that also inhibit steps in the heme synthesis. And finally, decrease in globin chain synthesis as you get in thalassemias and other hemoglobinopathies. All of these can cause microcytic anemia. So anemia of chronic disease, as we said, is mild, non-progressive, in contrast to iron deficiency anemia, which is usually severe, more severe. And as we said, this is due to the increased hepcidin levels, which decrease iron availability by inhibiting the activity of ferroportin. Sideroblastic anemia, as we mentioned earlier, has to do with inhibition of heme synthesis. It could be a hereditary problem. It could be acquired inhibition of heme synthesis. Normally in the bone marrow, there are sideroblasts that are precursors of erythroblasts, or erythroblasts, precursors of erythrocytes, which show iron granules in the mitochondria. These in sideroblastic anemia form a typical ring structure around the nucleus, indicating that iron is clustering and it cannot be incorporated into heme. Sideroblasts, an increase in sideroblasts in the bone marrow suggests, a ring sideroblasts in the bone marrow suggests sideroblastic anemia. And the treatment for this is blood transfusion. There's nothing else that can be done at the present time. So if a patient presents with hypochromic microcytic anemia, how do you make the diagnosis? How do you differentiate between the various causes of hypochromic anemia? Well, obviously, you start out with the history. You ask about bleeding, about presence of chronic diseases, family history, etc. You do a physical exam, look for splenomegaly, which is normally associated with thalassemia, as you will see later, or other findings of iron deficiency, as we discussed earlier. The tongue changes, the mouth, but these are usually extreme cases. We rarely see them nowadays. And then you go to the lab test. And in the lab tests, let's see how we can differentiate between them. So the mean corpuscular volume and mean corpuscular hemoglobin are reduced in iron deficiency, as is expected. Similarly, in chronic inflammation, where you don't have utilization of iron. In thalassemia as well, microcytic anemia and sideroblastic anemia. Now, the serum iron, on the other hand, is reduced in iron deficiency, as you would expect, and in chronic inflammation, but not in thalassemia and sideroblastic anemia, because there's no problem with iron availability in those cases. It's a different problem, which is the synthesis of hemoglobin. Total iron buying capacity is increased in iron deficiency anemia, but may be reduced in chronic inflammation and normal in the others. Ferritin, on the other hand, is uniquely reduced in iron deficiency. That's the indicator that you have iron deficiency. It's normal or raised in the others. And so a critical test to do if you are suspecting iron deficiency, as we already mentioned, is serum ferritin. And it allows you to differentiate between iron deficiency and the other causes of microcytic anemia. Bone marrow stores are absent in iron deficiency, as you would expect, as is the erythroblast iron, which is both absent in iron deficiency and in chronic inflammation. These are not the stores, this is the erythroblast iron. That is iron being incorporated into the erythroblast? And the answer is no. Hemoglobin electrophoresis is a way of detecting what kinds of hemoglobin are present in the body, and it's normal in all the cases except thalassemia, which is a problem with the hemoglobin synthesis chains, the globin chains. And that's where you see an elevation of HbA2, for example, in beta thalassemia. Now, in thalassemia, the serum iron may be increased. There might be an overload of iron, particularly in those thalassemics that are receiving blood transfusions as a treatment for the anemia. They are getting increased iron delivery to the system, and this can cause toxicity later on. Same with sideroblastic anemia. What is the treatment of iron deficiency? Well, as you'd expect, it is supplemental iron, supplementing the person with iron. So the approach to treatment of iron deficiency depends on the severity and, of course, the cause of it. So, for example, if you have excessive bleeding and you have a hemodynamic instability, that is, the blood pressure is affected, you should immediately intervene here and give a blood transfusion to restore blood volume and RBC counts. However, if it is a chronic anemia, then in these situations you find that the individual has a remarkable ability to adapt to this chronic decrease in RBC. Sometimes you see levels of hematocrit and hemoglobin that are extremely low, that yet the person is functioning almost normally. So in these cases, you can simply provide iron as a replacement therapy orally. And this is the case in the majority of the patients. However, there are few who cannot tolerate this, and therefore we have to resort to parenteral administration of iron. So when you're treating, of course, the first thing you want to make sure of is that there is no cause of bleeding. There's no bleeding that's causing the loss of iron. Otherwise, your therapy will fail. So again, any iron deficiency in an adult male requires investigation for sources of blood loss. So you treat the underlying cause if there is an identifiable cause. Then, in order to really treat rationally, you have to sort of estimate or calculate what is the amount of iron deficit in this patient. And you have to figure that if this, whatever the cause is continuing, such as heavy menstruation, then probably you have to maintain the replacement as long as this cause is continuing. So iron is available as oral pharmacological preparation. These are the various forms that are available. It has different amounts of elemental iron in the preparation as such. So some of them have 20% up to 33% for ferrous fumarate. And any of these can be used, but you will have to calculate the correct dose based upon the percent of iron present in the preparation. So iron is preferably taken on an empty stomach if you are taking it orally. Your goal is not only to correct the anemia. Remember, the anemia has appeared after the stores have been depleted. So your aim is, yes, to correct the anemia, which you can do quickly. But if you stop there, then you will not have actually replenished the stores of iron. So you have to continue treatment until you are sure that you have replenished the body stores. And that's why you have to calculate the total body deficit of iron. So as the anemia resolves, remember that anemia and decreased iron levels are one cause for increased iron absorption. So as you are treating the anemia, the rate of iron absorption is going to gradually decrease from the start of treatment till the end of treatment. And you have to take that into consideration when you're calculating the dose and how long you're going to treat. Usually, it requires sustained treatment for several months, even after the anemia has been corrected, in order to refill the stores. Normally, if there is a good response, if there is no continuous bleeding, if there is no other factor interfering with the treatment, the hemoglobin levels should increase by 2 to 3 milligrams per deciliter every 3 weeks. Okay, most disturbing side effects are GI problems, pain, nausea, vomiting, and constipation. Parenterally, you have also several preparations of iron. Iron dextran is a colloidal solution of ferric oxyhydroxide. A lot of hypersensitivity reactions. There are other preparations which include ferrous hydroxide. Again, this has a potential of causing kidney damage, but it is currently available at AUBMC. The last one, sodium ferric gluconate, is the most preferred for these patients, but I don't think we have it at AUB. Why do you fail? If you fail, it means that there is possibly continuing hemorrhage from somewhere, non-compliance. The third common and thing you should think about is that perhaps you have the wrong diagnosis. You may have a microcytic anemia, but it may not be iron deficiency anemia. So thalassemia trait, that is not a full-blown thalassemia, a heterozygous person may have a certain degree of anemia without the full-blown picture of thalassemia. And that might be mistaken for iron deficiency anemia. If you have mixed deficiencies, and you will be studying later about folate or B12 deficiency that can themselves cause anemia. If you have combined iron and folic acid deficiency, then the person may not respond adequately to iron. As we said, other causes of anemia like malignancy, chronic inflammation, malabsorption, and slow release preparations usually do not respond well. How do you calculate the iron deficit? Well, you have to take into consideration several factors here. Let's go through an example. The total iron deficit actually in milligrams is the body weight that times the target hemoglobin concentration minus the actual hemoglobin concentration. That is, if you are an adult male and you want a hemoglobin concentration of 15 grams per deciliter, and your actual hemoglobin is 10, then you have to account for this deficit. This is the deficit in the erythroid. You multiply it by body weight and you multiply it by a factor that accounts for the concentration of hemoglobin and RBCs in the body. And then you add on top of this the iron store replacement. You assume that this person has lost all the iron stores. You estimate the iron stores in this adult male, which should be around 1 gram perhaps. And then you add this to the actual deficit in the erythroid iron that you have calculated. And that will give you the total amount of iron that you should administer. So in a 60 kilogram female, hemoglobin of 10 and a target of 15, and body stores of 500, let us say, milligrams of iron, the total iron deficit will be her body weight 60 times 5 times 2.4 plus 500, which will be 1.2 grams of elemental iron. Now, where does the 2.4 come from? This is the derivation of this formula. And it tells you that iron content in hemoglobin is 0.34%. 0.34 grams per 100 grams of hemoglobin. Your blood volume is 70 milliliters per kilogram, or 0.7 deciliters per kilogram. The hemoglobin concentration is in grams per deciliter, remember that. So if you calculate the total iron in hemoglobin, the total iron in hemoglobin is going to be 3.4 milligrams times the total grams of hemoglobin in the body. What is the total hemoglobin in the body? Hemoglobin is found in the blood. So it's the blood volume times the concentration of hemoglobin. in the blood, right? So the total iron is therefore 3.4, the total iron in hemoglobin times 0.7, which is what you derived from before, times hemoglobin concentration. This will give you a factor of 2.4, 3.4 times 0.7, which multiplied by the hemoglobin concentration will give you the total iron per kilogram. And you multiply this by the body weight to give you the total iron. And that's what you do. That's what we did in the previous formula. If you go back, we calculated the total iron under normal conditions, total iron under the iron deficient conditions. We got how much iron was lost. We added to that the stores that we must replenish, and this gave us the total iron to be administered to this person. So if for that woman, it's around 720 milligrams above the body iron stores. So if she is depleted totally of iron, her iron absorption is going to be very fast at the beginning, which is approximately 20% of the iron intake. So let's take a drug like ferrous sulfate, which has a content of 0.32 grams of iron in one tablet of this drug. Okay, how much of it is going to be absorbed? At 20%, it's going to be 12.8 milligrams per day if you give one tablet per day. So 12.8 milligrams per day are going to get into the system. You need 1,220 milligrams. If you divide this over 12.8, you're going to need 95 days to replace this deficit. And this is the shortest time needed to replace the deficit. Why do you think so? Why? The answer is because we calculated this amount based on a maximum absorption of 20% iron from whatever is taken. But remember, this 20% is going to decrease with time, because as you replenish the iron, the rate of absorption of iron decreases. So in fact, it's going to take more than 95 days, at least 3 months, say 4 months. So treatment has to continue for around 4 months with this dose of iron so that you can replenish the stores. As we said, the anemia will recover much quicker. 2 milligrams of hemoglobin percent per deciliter, 2 grams per deciliter will increase every 3 weeks. Okay, now next, the last topic on our agenda is iron poisoning or iron overloads. So you see this mostly with children. And in these, we should be careful. 1 to 2 grams given to children can cause death. In most patients, 2 to 10 grams can be deadly. The most acute side effect or effect that you observe are GI effects, abdominal pain, diarrhea, and vomiting. But then this can progress as levels increase to pallor, lassitude, drowsiness, and cardiovascular collapse and death. So there is a sequence of events that is unique to iron toxicity. So as we said, the first stage is GI problems, and this can happen within minutes when you get an overdose of iron, and can last for several hours. This is associated with the corrosive effect of the iron on the mucosa of the GI tract. So you get these changes, these symptoms: abdominal pain, diarrhea, fluid loss, electrolyte loss, and you have to manage this accordingly with supportive therapy. The second stage, if the patient survives, stage 1, is a quiescent phase. It appears that patient has stabilized and there are no more any abnormalities. However, the third stage ensues because it's a delayed stage at which time iron has caused damage to various organs in the body. And result can be organ damage, marked acidosis, and shock and cardiovascular collapse. So this usually happens hours or starts hours after you take the iron in and can go on for days, can be as delayed as 24 hours to appear. The fourth stage, this can either go into severe problems and death, or it can result in chronic consequences that are most likely due to fibrotic changes happening after the damage to the organs has taken place. So you can get strictures and in the stomach and pyloric stenosis, so obstruction to flow. You can get hepatic necrosis, and this can lead to death as well. How do you treat the overdose? In an emergency situation, you immediately determine serum iron. If above a certain threshold, like 3.5, you have to give an iron chelator. You have studied the chelating agents previously. Deferoxamine is a specific chelator for iron, and it can be given intravenously and should be given as fast as possible. If it is less than 3.5 milligrams per liter, then you can try to do a washout from the stomach, induce vomiting, and one way to count how much you have in the GI tract is to do X-rays. So deferoxamine is a drug that binds iron. It binds ferric more than ferrous, and it can extract iron from hemosiderin and ferritin even. The problem with it is it is poorly absorbed from the GI tract and therefore must be given intravenously. Primarily intravenously, although you can give it intramuscularly and subcutaneously if you have chronic situations such as overload of iron associated with thalassemia and repeated infusions. But when you have an acute overdose, it's preferable to give it intravenously. The hemoglobin, interestingly, that's found in the cytochromes in the ferrous state are spared usually at therapeutic doses. So that is a good thing. That's a selective sort of action of the deferoxamine. Its toxic effects can cause hypotension if it's given too rapidly. Allergic reactions can happen, and many other symptoms, side effects have been reported. Deferiprone is another iron chelator that, in contrast to the peroxamine, is orally effective, so that's an advantage. And another specific thing about it is that especially effective in removing cardiac iron deposited in the heart. And adverse effects, like the other one, GI discomfort, arthralgias, but also it can cause agranulocytosis and neutropenia, and therefore one has to monitor the blood count when you are giving it. Deferasirox is a third agent that's also orally effective, and like the others, binds to iron in the ferric form, much lower affinity to copper and zinc, and again, GI symptoms might have some liver toxicity and kidney toxicity. And this table summarizes the properties of the three drugs, the degree of chelation, the route of administration, a very important consideration. The doses, the schedule, again, this is important for compliance, daily versus 3 times a day, for deferasirox versus deferiprone, the adverse effect profiles, the advantages, cardiac iron thing for deferiprone, and the disadvantages and the cost. The highest cost is for the latest drug, deferasirox. So all of these are considerations in selecting which drug to give. So finally, let's talk about the consequences of iron overload and the issue of hemochromatosis. So iron overload per se is referred to as hemosiderosis. It can result from increased absorption. And remember, when we discussed the regulation of iron absorption, we said that there are certain conditions that are associated with inability to inhibit ferroportin activity, iron absorption, due to a hepcidin problem. And this results in hereditary hemochromatosis. Hemochromatosis, as we'll see, is iron overload associated with injury to internal organs. Increased absorption happens where you have ineffective erythropoiesis and chronic liver disease as well. So when you have increased absorption, increased iron intake, and particularly when you have repeated RBC transfusions to treat anemias in such patients as thalassemics or those with sideroblastic anemia. The deposition of the iron in tissues eventually can cause organ damage, and that's when we talk about hemochromatosis. So hemosiderosis, organ function is maintained. Hemochromatosis, extreme accumulation of iron leading to organ damage. Hereditary hemochromatosis is an autosomal recessive disease where you have an increase in iron absorption, and it deposits in the organs and causes dysfunction, and eventually you get fibrotic changes in the organs. This is a slow process, and it starts in childhood, but it takes time to induce the damage, so the symptoms and signs appear later in life. Pancreas, liver, heart, endocrine organs are affected. So you get diabetes, cirrhosis, heart failure, and hypogonadism. Hereditary hemochromatosis has multiple types depending on the nature of the abnormality. Type 1, for example, is the classical. It's the most common type. It's quite common in Northern Europeans, and it's due to mutations in the HFE gene, and this results to upregulation of the dimethyl transporter in the intestines, and as a result, inappropriate increase in absorption of iron. The other type, which is juvenile, is the one that is caused by mutations in the hepcidin gene. So hepcidin can no longer inhibit absorption of iron. There are others in transferrin receptors and in the ferroportin mutations that we will not really go into. So iron overload occurs in patients, as we said, who require transfusion, regular blood transfusion. These are people like thalassemics, those with sickle disease, etc. The cardiac overload or iron overload in the heart is the leading cause of death in these patients, particularly in thalassemics who are repeatedly transfused. Now, why? Because look at how much iron there is in a transfusion. In each unit of packed red blood cells, you have 200 250 milligrams of iron. Remember what you get normally every day from your food. It's around 1, maximum 2, 1.4 in females, 1 in males, milligram of iron. So you can appreciate how much iron is being dumped into the body by a single transfusion of red blood cells. So how do you know if there's too much iron in your body? Obviously, serum ferritin concentration is essential. This tells you how much stores you have, plus the other measures that you can do. But also one can do a liver biopsy and magnetic resonance imaging of the internal organs. And the next slide shows you, first of all, this is a stain of a tissue from the liver. And you can see that on the left side, iron is heavily deposited in the liver, thanks to the blue color. And when treated with iron chelators, look what happens to the liver picture. Almost a complete removal of iron with some remaining stores there. And on magnetic resonance imaging, you can actually see the iron deposited in the liver on the right side here. This is the liver, this is the spleen, and this is the heart. And you see the iron deposit in the muscle of the heart. And on the left side, of course, you see the normal situation. So what is the treatment of iron overload? As we discussed earlier, you can use iron chelators. But another more effective and quicker way of reducing total stores is by actually removing blood from the patient, venesection. And every 2 or 3 weeks or so, depending on how much iron overload there is, you can remove a unit of blood. When a patient goes to the hospital, it's as if they're donating blood, but this is just being removed for therapeutic purpose. Okay, so with this we end the discussion of iron metabolism, iron deficiency, and iron replacement and overload. Thank you.